हेलो फ्रेंड्स, मैं डॉक्टर रुचिका गर्ग, एसोसिएट प्रोफेसर इन एसएन मेडिकल कॉलेज और आज हम पढ़ेंगे एक्लेम्शिया के बारे में. इट्स अ वेरी इंपॉर्टेंट टॉपिक. Whenever a pre-eclampsia patient develop convulsions or fit, it is called eclampsia. Pre-eclampsia, when complicated by generalized tonic-clonic convulsions and coma. So its incidence is about 1 in 500 to 1 in 30 pregnancies. Uh, it's more common in primigravida, more common in twin pregnancy. Most commonly it occurs antepartum, and that too in the late, mostly in the third trimester. Antepartum 50% occurs, intrapartum, that is during delivery, in 30%, and 20% postpartum cases. If it is postpartum eclampsia, then the prognosis is definitely worst. What are the causes of convulsions? It is because of cerebral irritation, cerebral edema, and cerebral dysrhythmia, because of the spasm of cerebral blood vessels. There is generalized spasm of the blood vessels of the whole body, so there is cerebral hypoxia, and there is cerebral edema. There might be infarction and hemorrhages because of hypoxia and ischemia. Clinical features, it's divided into 4 stages: premonitory stage, tonic-clonic stage, and then stage of coma. Sometimes the patient may have some premonitory symptoms before the development of convulsions. Patient may become unconscious, there may be twitching of muscles of face, tongue, limbs, eyeballs roll or turn to one side, become fixed. It lasts for about 30 seconds, then whole body goes into a tonic spasm, respiration ceases, tongue protrudes out, cyanosis appear, eyeballs become fixed, followed by a clonic stage in which the voluntary muscles of the body undergo alternate contraction and relaxation. Twitching, it starts first from the face, that involves one side of the extremities and ultimately the whole body, and there may be tongue biting, breathing labored, blood stained frothy discharge, cyanosis gradually disappears and lasts for about 1 to 4 minutes, followed by the patient remains in a stage of coma. And then what is status epilepticus? There are multiple fits occurring, then that is called, you can see the tongue bite. Differential diagnosis is epilepsy, number 1. Number 2, hysteria, because in young girls it might be there, but you can differentiate. Then in India, tubercular meningitis, encephalitis, puerperal cerebral thrombosis, it could be some poisoning, and in India cerebral malaria should be ruled out, or some intracranial tumor, trauma. Prognosis, immediate mortality, it has a definite mortality and a very morbidity. What are the causes of maternal death? Heart failure, lung edema, aspiration pneumonitis, cerebral hemorrhage, then multisystem failure, acute renal failure, cardiopulmonary arrest, ARDS. The patient may pass into acute respiratory distress syndrome, postpartum shock, and puerperal sepsis. These things ultimately follow, and has a perinatal mortality of about 30 to 50%. Also, fetal complications include preterm labor and prematurity, intrauterine asphyxia, because the whole blood supply is hampered, infarction. Now, management, how to control the blood pressure to prevent it. Prophylactic magnesium sulfate therapy in patients who have severe preeclampsia. Patient should be transferred to a tertiary care center. Shout for help, always call for help, maintain airway breathing circulation, administer oxygen at the rate of 8 to 10 liter per minute or as required, arrest convulsions, ventilatory support should be given, injury, tongue bite should be prevented, so tongue gauze should be given. Hemodynamically, the patient should be stabilized, and our aim is to prevent any complications and to provide her care. Definitive treatment is termination of pregnancy, डिलीवरी जितनी जल्दी हो जाए, दैट्स द बेस्ट थिंग. Anticonvulsants, magnesium sulfate is a drug of choice. Now coming, what is the mechanism of action of magnesium sulfate? The level is 4 to 7 milliequivalents per liter. Magnesium sulfate acts as a membrane stabilizer and as a neuroprotector. It reduces motor and plate sensitivity to acetylcholine. It blocks calcium influx, and it induces cerebral vasodilation because there is vasospasm, dilates uterine arteries, increases production of endothelial prostaglandins, and inhibit platelet activation. So So what is the mechanism of action? It reduces motor end plate sensitivity to acetylcholine and inhibits calcium influx, and as a membrane stabilizer and as a neuroprotector mainly, and also causes cerebral vasodilation. So Zospan regimen is IV regimen, Pritchard regimen is intramuscular regimen. Magnesium is always also a fetal neuroprotective. It prevents Alzheimer's disease in cerebral palsy. So Pritchard regimen 4 gram IV is given over 3 to 5 minutes as a loading dose, 20 ml of 20% solution. In a 20 ml of syringe, 4 gram, if it is a 50% solution, then it will be 8 grams of, 8 ml of this thing, and 12 ml of normal saline you take, and it will be 20 ml solution. So magnesium sulfate comes as a 50% solution injectables many times. This is the 4 gram IV and 5 grams in each buttock, 50% solution, and maintenance dose is 5 gram intramuscularly for every 4 hours till 24 hours has passed, or till 24 hours of delivery. Now intramuscular, you see 8 ml we have and 12 ml of normal saline, and along with that we can give some local anesthesia, 1 ml of 2% lignocaine to reduce pain, and then 5 gram in deep in each buttocks. But magnesium sulfate can cause toxicity. So during magnesium sulfate toxicity, what is important is patellar reflex should be present, respiration should not be depressed, and urine output in previous 4 hours should exceed more than 100 ml or 25 ml per hour. Minimum urine output should be there. In case of recurrent fits, half loading dose again is given, 2 gram intravenously, and 4 ml of 50% weight by volume solution dissolved in 6 ml of normal saline to make 2 gram solution is given in 10 ml. So this is the therapeutic level, 4 to 7 milliequivalents per liter. It's a frequently asked question. At 10 milliequivalents per liter, patellar reflex disappear. At more than 10, respiratory depression is there. So first thing to go is patellar reflex. This is often asked. Then respiratory depression. Then respiratory paralysis and respiratory arrest. And calcium gluconate is the antidote for magnesium sulfate poisoning. If the level of magnesium sulfate is more, if the patient passes into renal failure and is not able to excrete it. Neonatal respiratory depression only if severe hypermagnesemia has occurred. Neonatal compromise does not occur. Magnesium sulfate is this dose is generally not very tocolytic also. So calcium gluconate injection comes in a 1 gram intravenously without withholding further magnesium sulfate, reverses moderate to mild respiratory depression. Tracheal intubation and mechanical ventilation should be done. So magnesium sulfate is a very important short note, and you will get the questions in your table viva as well. Magnesium sulfate, it will control fits. It will reduce the chance of recurrent convulsions. It reduces maternal mortality and perinatal mortality. Along with that, blood pressure should be controlled. If the patient is in pulmonary edema, that is in congestive heart failure, diuretics should be given, Lasix should be given, IV 20 to 40 milligram. Zospan or Sebai regimen we should know, that is 4 to 6 gram IV over 15 to 20 minutes followed by 1 to 2 gram per hour IV infusion, because intramuscular regimen may be sometimes painful to the patient. Lytic cocktail regimen, it was previously used to given these chlorpromazine, promethazine and pethidine is given. Diazepam is given, phenytoin in 1000 milligram IV infusion in 1 hour, then 500 milligram 8 hourly. sometimes it is it is difficult to differentiate between eclampsia and this thing, because the patient is not able to give the history of high blood pressure, and sometimes it is normotensive eclampsia. Then we can epsilonize the patient by means of phenytoin. Lebibet, nifedipine, these are antihypertensive drugs which are generally given. Nitroprusside can be given under consultation with a physician. Hydralazine we very often give 5 to 10 milligram. We dilute it in 10 ml and 1 to 2 gram 1 to 2 ml is given at 15 to 20 minutes till satisfactory BP reduction is reduced. Lebibet, first of all 10 milligram IV is given, and every 10 minutes we can double the dose. Maximum 220 milligram can be given. Diuretics, they compromise placental perfusion. Hyperosmotic agents like mannitol should be used in pulmonary edema or cerebral edema only. RL should be given. Excessive fluid may cause congestive heart failure. Invasive hemodynamic monitoring may be required to avoid pulmonary edema. And delivery should be our aim. If cervix is favorable, then we can go for normal vaginal delivery. If cervix is not favorable, after stabilizing the patient, we can go for cesarean section under general anesthesia. Cesarean generally reduces the perinatal mortality and morbidity. These patients are less tolerant to blood loss. Epidural is preferred mode of anesthesia, but the choice of anesthesia depends on the anesthetist. Many times these patients also have thrombocytopenia. If platelet count is less than 60,000, then epidural anesthesia may not be the choice. Obstetric management, you can see whether the baby is term or preterm, then we can give steroids and we can plan delivery. Dead also, in labor we have to do ARM along with oxytocin, and forceps ventouse should be given to cut short the second stage of labor, because early delivery will better the prognosis. Magnesium sulfate should be continued for 24 hours following delivery, and sometimes CT MRI may be required in the postpartum period, because if the patient has some neurological deficits or neurological injury, multidisciplinary team should be there. She should be where ICU setup facilities are available. Certain complications like pulmonary edema, heart failure, anuria, hyperpyrexia, fever, psychosis can occur. So these manifestations, prognosis can be bettered by early detection, meticulous antenatal care. We should know high blood pressure patients beforehand, and blood pressure should be controlled so that they don't land in eclampsia. Timely intervention, and magnesium sulfate is the best thing. So all are prognostic indicators of PIH except here sodium. Pregnancy associated hypertension except here captopril. Inhibitors should not be given in pregnancy. Drug of choice for severe preeclampsia, nowadays Lebibet is the first choice. Best drug for management is magnesium sulfate. Levirapine can also be given nowadays in recurrent fits. 4 to 7 milliequivalents therapeutic dose. Earliest sign is depression of deep tendon reflexes. I have told you the levels you should know. Not a feature, eosinophilia. So thank you for listening to this video, and you can share these videos for more such medical videos with your friends, and like and ask your comments. Thank you. Bye bye. Take care.